was wrong. And now we know there's a number of medical problems associated with this disease, and it's definitely the most important thing, and that we always forget, is to start with basic healthcare maintenance. And this is not only common in patients with TTP. Any patient, I think, that has a severe chronic disease tends to pay all the attention to this disease specific and forgets about the general health screening. So we're going to talk about routine healthcare maintenance in terms of vaccines, routine labs, healthy living, age-appropriate cancer screening, and staying healthy in the COVID world. Last year, when we were talking about this virtual meeting, hopefully we were hoping it wasn't virtual, and then I was hoping I didn't have to touch that COVID subject, but unfortunately the Delta variant has changed the landscape completely, and I don't think we're gonna stop talking about COVID anytime soon. So the most important recommendation, if you need to get the first recommendation, if you need to get something out of this presentation, is to get a primary care physician. We are hematologists, we focus on blood diseases, and oftentimes that may be causing us to neglect other important factors of your well-being. So ideally, you can discuss with your hematologist. Maybe they know someone that worked with them in the community as a PCP and can help with just routine healthcare maintenance. So your primary care your PCP will help screening for high blood pressure, diabetes, high cholesterol, depression, and they should also assist with false prevention and screening for infectious diseases that have a treatment, such as HIV and hepatitis C. And it should also screen for osteoporosis in postmenopausal women younger than 65. And we know that patients with TTP have a higher risk of developing a number of long-term problems, such as high blood pressure, depression, post-traumatic syndrome, cognitive impairment, memory problems, and the best way to manage this is as a multidisciplinary approach with your hematologist, and starting with a PCP, and may eventually lead to other referrals. He will also take care of your vaccines. We used to think of a vaccine schedule as something that only children need to do, but actually adults have a number of vaccines that help us prevent diseases. And all these infections can potentially be second triggers, right, for TTP. So it can lead to the perfect storm and contribute to a TTP relapse. So it's even more important that we do everything in our power to prevent common infections such as the flu, which is a flu shot every year, that tetanus, diphtheria, and pertussis should be given, especially if you're thinking about getting pregnant or if you're pregnant. And it is also very important if you will be in contact with a newborn baby. Measles, mumps, rubella, varicella. So the zoster vaccine is to prevent zoster, which is a viral illness that causes a very painful rash, most commonly in older adults. So it's important to have. The HPV vaccine is the cause of cervical cancer, and it's given in 2 or 3 doses depending on the brand and the age that you get the vaccine. The pneumococcal vaccine, which there's 2 of them, hepatitis A, B, and the meningococcal vaccines. And finally, the Haemophilus influenza, we should not be confused with the flu shot every year. And these are vaccines that not all adults should get. The majority we should, but some of them your PCP will discuss with you depending on your risk factors. If you're a smoker, if you also have asthma, if you also have COPD, it's very important that you be vaccinated against Haemophilus. Moving on to cancer screening, 1 in 3 cancer deaths could be prevented with earlier detection. And there are 3 most common cancers that we can detect earlier. So cervical cancer screening, we should start with women aged 21 up to 65 years old. And this can be done in a variety of ways, with either a pap smear or checking for HPV. And it should be done every 3 years, and eventually can potentially be stopped if you have 3 negative tests. Colorectal cancer screening, this information is obtained from the United States Services Preventive Task Force, which is a group of physicians that provide recommendations based on the risk of getting certain diseases. And they recently went down on the age to start colon cancer screening from 50 to 45. And it can also be done in a number of ways, via colonoscopy every 10 years, or a sigmoidoscopy, or even just a test to look for occult blood. And breast cancer screening also recently changed the age for diagnosis to start testing with the mammogram from 50 to 40. And as a patient with a history of TTP, you're not at a higher risk than the average population to develop any of these diseases. But again, we want to keep you healthy so we can keep you out of the hospital. Of course, this is something that I'm sure you've heard before, but I want to repeat because it is very, very important. Just healthy living. So please try to stop smoking if you do, and don't start if you haven't started. And you know, patients with TTP, I'm sure you know better than me, may have strokes as their initial presentation of the disease, and smoking can also causes fatty deposits on the arteries. So really, it's not the best combination to have. The DASH diet is a diet aimed to maintain your blood pressure at goal, but also to keep you healthy. And of course, is based on adhering to the diet rich in fruits, vegetables, whole grains, and lean meats. Exercise, there's a number of studies that have shown that an exercise routine, even walking 30 minutes, have been associated with a reduction on symptoms associated with chronic fatigue that we know a lot of our patients have. And finally, going to the dentist every year, it's important. There's been studies that have shown that gum disease is associated with Alzheimer's and other vascular dementia. The reason for that is because there's about 700 bacteria in our mouth, and when you have gum disease, they can travel from the bloodstream to our brain. So knowing what we know now about long-term complications of TTP in terms of neurocognitive impairment is something to be on top of it. This is a question that we get from patients with TTP all the time, but also from the general population. Should I be taking a daily aspirin? So the United States Preventive Services Task Force does recommend a daily aspirin and a low dose, what we call a baby aspirin, or 81 milligrams, to prevent cardiovascular disease and colon cancer, but in only certain circumstances. So adults aged 50 to 59 who have a 10% or greater 10-year cardiovascular risk. And this is where your PCP comes in, and he'll evaluate you and take into consideration other medical problems that you may have, such as high blood pressure, high cholesterol, your age, family history, and whatnot, to decide if you would benefit from an aspirin. Of course, patients that are candidates for this therapy should not be at increased risk of bleeding. And people tend to think, oh, this is just a baby aspirin, nothing's going to happen. But it does increase your risk of bleeding. And it's something that if you take, definitely bring up to your doctor if you have an elective surgery, for example. Have a life expectancy of at least 10 years and are willing to take the low-dose aspirin daily for at least 10 years, because this is when we see the benefit of the medication. A word on pregnancy. So it's very important that you work together with your hematologist and your OB, ideally when planning to get pregnant. Start a daily folic acid. Try to maintain a healthy weight and a healthy weight gain during pregnancy. Your OB will also screen you for HIV, gonorrhea, and chlamydia, and take all COVID precautions. Okay, and then we move to healthy living on a COVID world. So this is the number of cases that we see now in the US. And of course, you see a trend, a spike high in the curve with the Delta variant. And if you live in certain states like Florida, where I live, actually, this is the worst time in the entire pandemic. So it's very important that we make sure that we try not to get COVID to stay out of the hospital. In summary, the recommendations to avoid COVID right now are to wear a mask, to vaccinate, but still wear a mask, to get the booster vaccine when you have a chance. So right now, the indications, the booster vaccine is open to the population that is considered immunosuppressed. That doesn't mean every patient with TTP. It just means patients that are maybe undergoing chemotherapy or had a bone marrow transplant recently. But in your case, it may include you if you are taking prednisone at least 20 milligrams daily. And I know many of you may have, because if you also have another autoimmune disease, maybe lupus, that for which you're taking prednisone, then you should get a booster. Stay at least 6 feet from others, avoid crowds and poorly ventilated spaces, and wash your hands often. I realize that reading the news, it's scary when we talk about COVID vaccine. Every day there's a new FDA warning, or it seems like it. You hear all these horror stories about patients getting the vaccine and then having clots, having low platelets. Actually, a patient or a member of this group made me aware that there was a report in Israel about a higher number of cases with TTP in their hospital after receiving the vaccine. So certainly there are concerns that I'm going to try to address to the best of my knowledge. The reality is that when you get the vaccine, what we know so far, right now, it's not, when we started giving vaccines back in December, we have a lot of information. There's millions of people that have received the vaccine, and we have better numbers about how often we get side effects from the vaccine. And local adverse reactions are common, meaning pain in the arm, redness around the area, and are usually self-resolved 1 to 2 days after the vaccine. But there's also other symptoms: fatigue, headache, muscle pain, less commonly fever, chills, and joint pain, all of which are also resolved in 1 to 2 days. Anaphylaxis is very rare. It's been reported in 50 episodes in 10 million doses. We know there's been an association, or what it's called right now, a chronological connection with the risk of developing TTP, and that's still under investigation. So far, there's only 2 reports of 2 patients that had TTP after the vaccine. And what I mentioned earlier was that in Israel, there's a hospital that has seen an increase in their typical number of TTP cases that they see in a year. So they think it may be because of the vaccine. Well, but we don't know for sure yet. There's another syndrome called vaccine-induced thrombocytopenia and thrombosis. This syndrome is rare, it's very severe, and is characterized by having clots in weird places, most commonly in the brain. And at the same time, patients have low platelets. And that combination, of course, can be dangerous because it can lead to bleeding, specifically brain bleed. The good news is that also is very rare. It's been reported in 1 in 50,000 people younger than 50 years old with the AstraZeneca vaccine that we don't have in the United States. And we know that the incidence is much less in older patients. This is something we see in younger patients. And it's also been reported with the Johnson & Johnson vaccine that we do have in the United States in 28 cases in 8.7 million doses so far. The case fatality has been 23% for AstraZeneca and 10% for Johnson. And we know that this syndrome is caused by autoantibodies against a fraction in the platelets that we see with allergy to a blood thinner that we use commonly in the hospital called heparin. And this occurs in the absence of heparin, but it's a similar reaction. We don't know what part of these vaccines cause this phenomenon. It's certainly something that has been reported only with AstraZeneca and the J&J vaccine, not with the mRNA vaccines, so not with Pfizer or Moderna. And also studies have shown no specific risk factors for this rare syndrome, meaning it's not more common in women, it's not more common in patients with a prior history of thrombosis or patients with a prior history of heparin allergy, certainly not in patients with TTP or ITP. Another concern was the risk of blood clots with the AstraZeneca and the Johnson & Johnson vaccine. But so far, there hasn't been a clear causal relation between these vaccines and either deep thrombosis in the legs, in the arms, pulmonary embolism. So far, we don't have a strong association between these vaccines and blood clots. So after telling you all this, why do I still want you to vaccinate? Because it's truly your best chance to be out of the hospital and die of this disease. Any vaccine that you choose will have approximately a 97% chance of preventing severe disease and death. And these are charts from the one on the left is from the hospitalizations in Oklahoma. And you can see how the majority of the hospital admissions are from non-vaccinated patients. Of course, like I said, it's only 97%, so it's not perfect, but definitely being vaccinated lowers your risk immensely. And the one on the right is from another hospital, another city, Austin, and the number of COVID infections that they had with this most recent wave. And again, the non-vaccinated really are unfortunately filling the hospital. I know that many of you may have a risk of what if I develop a clot with these vaccines. So the risk of blood clots have been associated only with the AstraZeneca and the J&J vaccine, not with the Pfizer or Moderna. And the risk is extremely low, 0.0004%, and much less riskier than things that many of us take every day, such as birth control, smoking, and the COVID infection. So now we know that COVID infection, and we noticed this right from the beginning, has a higher risk of developing blood clots, 16.5%, depending on the case series or the report that you follow, but certainly much, much higher risk of clots with the infection than with the vaccine. And we not only see blood clots in the legs, we see severe pulmonary embolism that are bilateral and that cause a number of tremendous respiratory problems as patients are discharged from the hospital. Patients also present with stroke. And at the same time, these patients can also bleed. So COVID infection, when it's severe, not only in the ICU, but just admitted to the hospital, can bring a number of bleeding and clotting complications, much more severe than the vaccine. The other reason to get vaccinated is the risk of long COVID. Long COVID is a term that has been in the news a lot, and it pertains to symptoms continuing for more than 12 weeks after the infection, either severe or mild, that can't be explained by another cause. And symptoms to make this diagnosis include extreme fatigue, shortness of breath, heart palpitations, chest pain, brain fog. Patients tell you that they can't concentrate at work, that they're forgetting that they need to do something that afternoon, pick up something, just memory problems overall, changes to taste and smell, and joint pain. Other medical problems have been associated, such as hearing and visual problems, memory impairment, hallucinations, and visual changes. And it's thought to be due to an overdrive of the immune system. It is more common in women. The incidence increases with age. It's seen in 1 and 2% of all the patients that get COVID in their 20s, but it goes up to 5% of people in their 60s. And to date, we have no proven drugs or diagnostic tests for these symptoms. And interestingly, half of the patients that had long COVID reported an improvement in their symptoms after the vaccine. And this is thought to be because the vaccine is helping you fight any remnants of the virus that you may still have. And it's also sort of resetting your immune system. So if you had COVID and you have symptoms of long COVID, getting the vaccine may potentially treat these. And of course, if you never had COVID, getting the vaccine is going to prevent you getting long COVID. So in summary, you should get a primary care physician, ideally someone that works with your hematologist, that is going to screen for common illnesses, is going to keep you up to date with your vaccines, maintain a healthy lifestyle and cancer screening, work closely with your hematologist through any period of time, but this is also more importantly if you plan to get pregnant, follow the COVID-19 precautions and get the vaccine to prevent death, thrombosis, and long COVID. And now we'll move on to the panel for questions. And this is my email below, and you can email me if you have any questions And I'm more than happy to see any patients that are in South Florida with TTP. Thank you.
Hi, I'm Dr. Marshall Mazeppa. I'm a hematologist at the University of Minnesota.
It's over here. That's the camera that's
Okay, my name is Dr. Mohammed Kawandana from University of Oklahoma.
So we're gonna start reading the questions that we got through the Q&A box, again in your bottom right corner, and then we'll discuss also some that we got through the website. So I received Rituxan for 4 weeks, 13 months ago, as my Adams CS13 went down to 30%. This keeps me until control for about 2 years. I am not vaccinated. If my physician's okay vaccination for me, will this hasten a drop in my Adams CS13 levels?
I can start.
Okay.
Yeah, you want me to start talking?
Sure.
So this is a very common question that people have. And that is, we know that this disease is caused by sort of an error that's happened in the immune system. And certainly any trigger to the immune system can cause the immune response against TTP to worsen. So in having these discussions with my patients, we have talked about doing more monitoring around the time of a vaccine. There isn't currently a way to really predict what's going to happen when we give the vaccine. But again, I think your talk was great because I think overall the risks and benefits have to be weighed, right?
Yes.
We don't have a crystal ball. And so when you think about the risks of COVID infection and long COVID compared to the small, but there are risks of the vaccine, I think most of us come out in the end to say, look, the risks of COVID are much higher than the vaccine. Now, one of the potential risks that's unique to people who have TTP is that it could potentially trigger the immune system to cause a relapse. But I think if we're prepared that that is one of the unique possibilities of the vaccine and we can monitor that, then at least we can deal with that possibility. I mean, this is the reality of medicine. There are risks and benefits to everything we do. And so I think as long as we have that discussion about this as a potential risk, then that's a good conversation. The other part is that rituximab does have an effect on our ability to respond to vaccines. So that's always a conversation I have with my patients about if we're talking about rituximab, what's the timing? So maybe I'll pass that off to you.
Okay. Or do you want to comment anything else?
Sure. We can address that separately.
Yeah, so the question regarding the timing, patients who are on active Rituxan, or we extrapolate some of the data from bone marrow transplant patients and lymphoma patients when they get chemotherapy. The American Society of Hematology recommending for bone marrow transplant patients to get after 3 months to 6 months after end of therapy. So I don't know about your opinion on that.
Yep.
TTP patients.
So I think we can divide this question into parts. One is the risk of having TTP with the vaccine, right? In any TTP patient. And there's certainly a risk, but at this point being, given the numbers of cases reported, I would say it's a remote risk. And you can be, of course, very close monitored. Certainly there is a risk of having a TTP episode, I would say much higher with the infection. So again, I can't tell you that the vaccine is not going to drop your levels, but I would tell you that your risk of having a relapse with the vaccine, I think, is much less likely than with the infection per se. And then the other question is, what about sort of the relationship between TTP, rituximab, and COVID and the COVID vaccine? And we know that rituximab, and we can extrapolate this from the malignant heme population, that patients on rituximab are a high risk of developing COVID. And so if you are gonna get rituximab for your TTP, I would encourage you to keep quiet, stay at home, use your mask, maintain your distance for the duration of treatment and a few months later, and get the vaccine either, as Mohammed was saying, either 3 to 6 months after, or if you can time it, maybe even before the starting of rituximab.
Right, and I think I've advised my patients the same way. If it's possible to try to get the vaccine before your doses of rituximab, or if you're having need treatment sooner than you can get the vaccine, than waiting a few months. There is some information that we know that some patients after rituximab have a blunted response to vaccines, and that can last up to a year. I think the reality is with vaccines is that even though we can measure some activity of the immune system, we don't have great ways of showing exactly how protected or not protected you are. So even if your response to the vaccine is a little blunted, it's probably still better than not getting the vaccine. And everyone's different. And a few of my patients who've gotten rituximab and then gotten the vaccine afterwards, we have checked antibodies, so the response of the immune system to the vaccine, which also isn't a perfect test by any means, but it's one strategy we can use to see, is there some response? Again, it's not perfect. We can't see by this test you're 100% protected or not. But there are strategies you can talk with your doctor about, around getting the vaccine and timing with rituximab.
Mm-hmm. Yep. And this question is also related to that. If I received the vaccine after getting Rituxan right before it, but I'm not receiving Rituxan now, does that still make me eligible for the booster since I was immune suppressed when I got it? Yeah, that's an excellent question. I would say that, I think that specifically rituximab treatment, they certainly included any chemotherapy. So I would say that after you receive rituximab, you're immunosuppressed for the next 3 to 6 months. So I would get a booster, yes.
I agree. I think the reality is that when weighing risks and benefits, it's unlikely to harm you to get a booster, and certainly other serious potential benefits, particularly if your immune system wasn't able to respond as robustly at the time that you got the initial vaccine.
Yeah. And I want to make the point that I think right now you'll see on the news that the booster for the general population is being recommended 8 months after you got the first dose. And I'm not quite sure where that number came from. I think that studies have shown that patients have antibodies after receiving the vaccine up to 6 to 7 months. So having said that, maybe not get a booster every month, but definitely around 6 to 8 months, I think it's very reasonable for everyone.
And what would you guys recommend as far as testing before getting a vaccine and testing after a vaccine? We have a few people that are wondering about if you can tell if you have antibodies developing from the vaccine. And if they should get their Adams TS13 tested before and after.
Do you wanna?
Um, Yeah, so currently in my practice, I'm not really recommending any specific testing prior to initiation of therapy, like in terms of checking for IgG or IgM or anti-spike or nucleocapsid. But I get this question a lot, and some of my patients would request some sort of testing to basically gauge the need for a boost or further immunization. What do you do in your practice?
Yeah, I haven't tested anyone for antibodies before a booster discussion. So I guess part of this is sort of another two-part question. Part of it is what's happening with your Adam TS13 before a vaccine, and then sort of COVID antibodies. So maybe we should separate those. I would say I've had much more discussions around testing Adam TS13 activity before the vaccine. To try to understand what's the likelihood that the vaccine could trigger a relapse. So in a few patients who we've done this in, I've tested before they've gotten the vaccine, and then I've tested a few weeks after each dose of the vaccine, whether it's a 1 dose or 2 dose. In my limited experience, I haven't seen the vaccine cause Adam TS13 to drop, but again, that's, these are small numbers. I think the question of the COVID antibodies is a potentially more nuanced question. I think there currently isn't any real guidance on using that testing to decide about a booster, but certainly you could do that. I think it really more comes down to timing. If you think at the time you got your vaccine that you may not have responded well, I think that's probably a more accurate way of measuring or of deciding upon the need of a booster rather than the antibodies.
Yep, I agree. I think in terms of testing for Adams TS13 before the vaccine, I think it's very reasonable, and that's what I've been doing as well, because having a non-deficient Adams TS13 activity before giving it makes me think that most likely this patient won't have a relapse. It can certainly still happen, and that's why we follow them closely, maybe check in the next 1 or 2 weeks. And the patient, of course, needs to be aware that if they have any symptom, the patients tell us all the time that they know they have a relapse. So if they have any symptoms that they know of are common for the relapse, to let us know. I also want to point out on that note that the cases that have been reported with having TTP after the Pfizer vaccine have been resolved quickly. Patients recovered really well using plasma exchange steroids and caplacizumab, and there's been no deaths. So that's also very good. Of course, we're not checking Adams TS13 levels in the general population, right? Because this is a very rare event. And in terms of how do I know if the vaccine is working, and checking antibodies, which I think it's not only a question for patients with TTP, but everyone wants to know if they're still immune to the disease all the time. I don't think it's recommended to test outside of a clinical trial, and the reason for that is because I don't think that to date, and correct me if I'm wrong, but I'm not quite sure that there's a consensus on what's the best test to check for antibodies, because the immune response to COVID is very complex. And even if you appear not to have your antibody maybe low, maybe in the lower side, but still positive, you're still immune. So that's why we're not testing it routinely.
Yeah, I think that's a great point, is that the body's immune system is highly complex. Antibodies are something that's a protein in the blood, so something that we can easily measure. The problem is that there are many ways to measure it, and it may not be the thing that's really protecting us. It's a part of a larger immune response. And so, like so many things in medicine, it's helpful, but it's not the whole answer.
Yep.
So I think that's why we're seeing, even though the test is out there, it may not be as informative about how protected or not protected one really is.
All right, and we've got a question here, just wanting to break down a little bit. What is Adams TS13? This is a newly diagnosed patient who doesn't, wants a little bit more layman's terms. What exactly is Adams TS13? What is its role? And why would you give rituximab to help a TTP patient? So that should fill in the next couple hours.
Sure. Well, I can get us started. So Adam TS13 is an enzyme, so it's a protein in the blood. Its main job is to break up another protein that's named after a famous doctor who unfortunately has a very long name, Dr. von Willebrand. So von Willebrand factor. And I will commonly describe von Willebrand factor like Velcro. And so if you think about in your body, when we want to stop bleeding, this Velcro clumps together tennis balls or platelets. So that's sort of the analogy, is that this von Willebrand factor wants to clump together our platelets and form a clot to stop the bleeding. Now, the job of Adam TS13 is to break up that Velcro so it isn't in big, long strings. And so when our level of Adam TS13 is low, we get extra long, big Velcro pieces that start clumping together the platelets like Velcro and tennis balls. And so in the most common form of TTP, called immune TTP, the immune system makes a mistake and starts removing or blocking the effect of Adam TS13. And this causes the downstream effect of big sticky Velcro clumping together the platelets. And so when people get the disease TTP, they get low platelets from all of it clumping together and forming blood clots in their small blood vessels. And so we tend to see most of the symptoms from TTP being caused by tiny blood clots, and the brain is particularly sensitive to this problem. So we've seen most people's symptoms related to those tiny clots, headaches, confusion, problems with memory. So Adam TS13 is kind of at the root of the problem with TTP. And most of our monitoring of the disease is related to that enzyme, at least right now. Do you want to talk about rituximab?
Will you say what a normal level for Adams TS13 is? Just
Oh, sure. So it's actually quite simple, and we basically talk about Adam TS13 activity in percent of normal. So we determine 100% is the typical amount of Adam TS13 most people have in their blood. And most people with an acute TTP episode have less than 10% of normal enzyme.
Yeah, so talking about Rituxan or rituximab, the name rituximab, it's a monoclonal antibody, which is basically a protein that lowers the immunity, and basically it targets a target called CD20, which is a structure on top of the B cells, which is one of the immune cells. And basically think about this TTP like an immune event, and rituximab will lower the immunity basically in that arena. It's usually labeled as chemotherapy, but in reality it's immune therapy. It's not like a real chemotherapy, and it comes in IV form. It's intravenous, and we usually start it in the acute episode of TTP, and in some cases after TTP for prevention.
Right, I think that, and we're gonna discuss this through the day, but certainly we know now that, rituximab, we use it to prevent relapses in the future. And remember when I started talking, I said, we used to think as TTP was a one-time thing, and then patients were discharged, never followed by their hematologist. And now we know that's certainly not the case. We know that about 30 to 40% of the patients will have a relapse. And the question is, there's many questions around it, but one of them is how do we prevent that? And one of the ideas is that giving rituximab when a patient is asymptomatic but has a low Adams TS13 activity on just routine monitoring by their hematologist may prevent relapses in the future.
Right, so the purpose of rituximab is to try to reduce that immune system's error and removal of the Adam TS13. So what we hope to see after we give the medication is that the Adam TS13 level will start to rise. In general, we think the lower the level of Adam TS13, that closer to zero, the greater the chance of another TTP episode. Of course, that being said, just because the level is low doesn't mean that a relapse will happen. And there are people who have congenital or hereditary TTP, which is a less common form of the disease, where their body makes very little or none of this protein. And TTP episodes happen, but not 100% of the time. So I wanted to introduce that term because we will hear that, and our next speaker is going to talk about the hereditary or congenital form of the disease. Though commonly when people refer to TTP, they're referring to the more common immune disease. And that's where we use the rituximab medicine with the intent to increase the Adam TS13 level.
All right, we had a couple questions regarding medicine caplacizumab, Capla or Capalivi, and how it works for TTP. So will the vaccine affect it? Is there an interaction? And how would you use it?
Do you want to start? No, do you want to start?
Okay, so caplacizumab, Cablivi, is a medication that was approved, I think, in 2019 with TTP, and it's really one of the novel treatments for this disease. I mean, after plasma exchange and steroids was discovered to aim at reducing the mortality from TTP, we didn't have any new medication up until 2019. So we're very excited to have it now as another tool for our patients. And what it does, it's gonna prevent the interaction between these very big, very long, ultra-large von Willebrand factor multimers and the platelets. And that way, we're gonna prevent clotting complications. We're gonna prevent clottings in the very small vessels, and we're also gonna avoid thrombocytopenia. It's important to know that Cablivi or caplacizumab is not gonna target the autoimmune component of the disease. So it's not aimed at suppressing the exacerbated immune response. And that's why we give it in conjunction with immunosuppressants and plasma exchange. It's not affected, the mechanism of action of caplacizumab or its efficiency is not affected by the vaccine at all. As a matter of fact, the patients that had TTP that have been reported in the literature after getting the vaccine were treated with caplacizumab successfully. So it's very good to know that it still works.
Yeah, I'm a visual person, so I'll go back to my Velcro and platelet example, a Velcro and tennis ball example for how this disease works. So I think of caplacizumab as basically sticking to the Velcro to prevent the platelets from clumping. The medicine doesn't last very long, it lasts a couple days. So that's why the medicine is given as an injection every day. And it really only affects the von Willebrand factor, the sticky Velcro. It doesn't have any effect on the immune system. And so it prevents those blood clotting complications and allows the patient to recover faster, but doesn't really have any long-term effect on the likelihood of another episode, or it doesn't affect the immune system. So certainly a different treatment than rituximab or prednisone or other corticosteroids that affect the immune part of this disease.
was trying to find the presentation. Let's find it.
All right. We also have another question regarding pregnancy and TTP. This patient was pregnant and suffered a late-term miscarriage, and that's when she was diagnosed with TTP. She was advised not to get the COVID vaccine at this time. Do you have an idea why this might be the impression? And this was by her hematologist. And she's concerned that the side effects of COVID would actually be worse than the side effects of the vaccine. And then she was also wondering about whether or not it would be safe or manageable for her to be pregnant again.
And can you repeat, when was her last, did she say when was her last TTP episode?
In June.
In June of this year. Yeah, I think that, there's always the concern that any vaccine or any infection can trigger another TTP episode. So maybe that's why her hematologist didn't want to recommend the vaccine at this point. I would say that if it's been more than 2 months since the last episode and you are not, and the Adams TS13 activity is normal, I would still recommend the vaccine, because I think that the odds of having the complications of the COVID-19 infection goes way beyond TTP as a disease, and will go, that conversation goes way beyond if you're going to have a relapse with the infection or the vaccine. It goes to talk about severe COVID infection and what that entails, and clotting complications, that long COVID, and other medical problems that you may have for the rest of your life. So I would still recommend the vaccine.
Yeah, I think it's hard for us as hearing the story to know exactly why a vaccine may be recommended or not recommended. But I agree that in general, the vaccine is less likely to harm than benefit at this point. So I would agree without knowing all the details about why that recommendation is made. I think the other thing too is I often encourage patients to get other opinions. And sometimes the opinion isn't different, but you may hear a different explanation. And sometimes that is very helpful to hear just a different way to explain the same decision.
Yeah.
And I think patients often worry that getting another opinion is going to be offensive to their primary doctor. And I think that's almost, I won't speak for everyone, but I think it's never offensive to me if a patient wants to get an opinion from a different doctor. I think that's with regard to the vaccine. I think overall, in general, we feel that the benefits far outweigh the risks, and that there are things that we can do in our TTP patients, like monitoring Adam TS13, that may help us mitigate some of those risks. I think the second part about pregnancy, we can move on in a second, but.
Yeah, so the issue with the pregnancy and the risk for TTP, so basically it's going to require a lot of monitoring between OB and the hematologist, and the risk and basically with monitoring and follow up with the OB, the pregnancy can continue safely.
Yeah, I would like to echo what Marshall said about seeking advice, especially in a rare disease, because we don't have all the answers, and even between us, there's not necessarily a consensus on the best course of action oftentimes. Every patient is different, and I think that, to your question specifically, can you get pregnant again or not? I think it requires a more detailed information that we don't have right now. Certainly, we wish that all our patients with TTP can get pregnant again if they want to. And that starts with a close monitoring, maybe some therapies to keep your Adams TS13 activity normal through pregnancy, but that's not something that is kind of done uniformly on a stepwise approach. So it would need to be discussed in detail.
Right, and pregnancy has long been recognized to be a common time when TTP is diagnosed. And so we understand that the risk for another TTP episode is higher during pregnancy. But right, with careful planning, understanding what we know about this phenomenon, what's unknown, what are the things that we can or can't do. So it's complex. And I think you want a team who has expertise in this area, both on the obstetric side and on the hematology side. So thinking about who's on your team, the term we use in medicine for obstetrics providers who specialize in high-risk pregnancies is a group of doctors called maternal fetal medicine specialists. So I think counseling with a maternal fetal medicine doctor even before you become pregnant, again, would be really important. Because really, it's about planning and understanding what is the game plan, what are the risks, what are the things that we can do.
All right, this is kind of a unique question. This patient had read a few articles about COVID patients receiving recombinant Adams TS13 as they'd seen a drop in their Adams TS13. Is that something you guys have heard of or were aware of?
I don't think recombinant Adams TS13 is available outside of a clinical trial right now.
Sorry, I should know. They did say that they were in clinical trials.
They did say.
Yeah, the COVID
Okay.
patients were in clinical trials, and that's where they received the recombinant Adams TS13. And if you guys just want to explain what recombinant Adams TS13 is and where it is in the development for TTP patients as well.
Okay. Do you want to start?
Sure, I can. So when we use the term recombinant, what we mean is that this protein is made in a laboratory instead of being collected from blood. This drug was developed now many years ago, where the drug was can be this protein that occurs naturally in people now can be created in a laboratory and in concentrated form. Right now, the only way to give someone Adam TS13 is in the natural form, which is in the liquid part of the blood we call plasma. So when we do plasma exchange, we're giving plasma, which naturally contains Adam TS13. So certainly it's exciting that this drug has been developed to be able to give higher, more concentrated form, higher levels of Adam TS13 than naturally occurs in plasma. And certainly there is interest in whether this medication could be beneficial to people outside of the two forms of TTP we've talked about, congenital and immune. I think those areas are still very much in development. But the drug has been tested in both forms of TTP, and there are ongoing studies of this medication in both diseases. So I think we see this as an emerging treatment because it's only available in clinical trials. And similarly, this may have been how this medication was used in this particular patient. So I don't think any of us have any experience giving this medication outside of TTP.
Yeah, I think that it's reasonable to think that the Adams TS13 activity in the general population drops. I don't know that to very low levels, but that's why there's a clinical trial on the use on that drug. But yeah, I haven't used it.
All right, thank you so much. We're going to end just a little bit early so we can transition to speakers. We appreciate our panelists joining us, and any of the questions that weren't answered, we will try and address in the Ask the Hematologist session, which is just kind of a grab all miscellaneous, ask us whatever you want session.